Before we start today's session, let me introduce myself. I'm Dr. Sumbali Jas, MRCG1 mentor by Instutors. Today is 8th of May, which is World Ovarian Cancer Day. And we Instutors team, we want to help doctors understand ovarian cancer better so they can treat their patients in terms of their clinical practice. They are in a better position to understand the different variation of ovarian cancer, and we want to help them that in that way we also want to serve the community. We want to serve the people who are suffering from this condition. And since many of you are studying for MRCG1, so we will also want to teach you and we also want to practice some SPAs, which are important from the exam point of view. So let's begin. So the World Ovarian Cancer Day is dedicated to bringing the issues to light about ovarian cancer, the most common cancer prevalent among women around the world. So again, I want to put some emphasis on this condition, on this cancer, that it is very important for every health professional, for every doctor, not just the gynecologist. Every doctor should know about the ovarian cancer so that they can address the patients in a better way. And again, in a better way, they can help the society. So the purpose of today's session, I want to brief that again. I want to teach you the basics of ovarian cancer, like what type of cancers we have, what are their different findings, how we can differentiate one type of ovarian cancer from the other, and what are their prognosis. And we know that some of the cancers are benign tumors. That means they are not that lethal. And there is another category which are malignant. That means they can spread to the rest of the body, and which unfortunately leads to very poor prognosis. So for that, we should have a better understanding of one of the each type of ovarian cancer. So let's begin with the risk factors of ovarian cancer. So let me tell you one thing. The most common type of ovarian cancer globally is the epithelial cancer. So does anybody know why the epithelial ovarian cancers are the most common type? Any idea? Is there anyone who have a good answer that why epithelial ovarian cancers are particularly the most common type of ovarian cancer? Because that accounts in the range of 70 to 80%. Yes, technically all the ovarian cancers are somehow associated with peritoneum. But why particularly epithelial cancers are the most common type? Okay, let me tell you what happens during ovulation. The follicle ruptures, which is secondary follicle, that ruptures and release the egg, which leads to the epithelial cell damage on the surface of the ovaries. And these cells undergo rapid division in order to heal the tissue. And we know whenever there is a damage to any part of the tissue, if anyone have a cut on their skin, then the cells divide and replace that damaged tissue with the new one, which we call that healing. So that's the same case with the ovaries, the ovarian epithelial tissue. During the menstruation, on each cycle, now you can imagine how much we are prone to having cancer if we have certain kind of genes, any certain kind of risk factors. So every month, with each of the monthly cycle, when ovulation happens, the egg releases from the ovaries, it leads to the epithelial cell damage. And in order to overcome that damage, in order to heal the surface of the epithelial surface of the ovaries, the cells divide and divide. And if at that point, if a person have certain genes, if a person have any family history of ovarian cancer, or any kind of trigger, if that person that have those triggers, then there is a chance those cells may rapidly divide and leads to the cancer formation or the tumor formation, you can say. So that's why the epithelial ovarian cancers are most common, because a person again is at risk of having cancer each month. So we should thankful to the nature, like our system is designed in a such a way that everything is so controlled, the cell division, cell repair, apoptosis, everything is so structured and so organized that we are living a healthy life today. So again, we should be thankful. So now link the risk factors, why I have mentioned that in the beginning. My purpose was to explain the risk factors and the protective factors. So now imagine if a person do not undergo ovulation. So answer me in the chat box, if a female who is not having ovulation, does she have increased risk of getting ovarian cancer or decreased risk of having ovarian cancer? Please do let me know. Yes, excellent. So if a female who have less menstrual cycles, or you can say less ovulation, the chances of getting her ovarian cancer, specifically the epithelial surface cell cancer, is reduced. So now let's have a look on the risk factors. And meanwhile, I will tell you what kind of questions are frequently asked in the exam and how you can extract those that information, those SPS from these slides. So I have highlighted the recalls, or you can say the high yield points in the red color. So if you get a question that what is the strongest risk factor for having ovarian cancer, then go and mark the family history, because this is the strongest risk factor among the others. So family history, nulliparous, first child after the age of 35, involuntary infertility, late menopause or early menarche. Because if you look at the late menopausal woman or any young girl who have early menarche, that means they have an increased amount of ovulation throughout their life. So that's a risk factor. Then hormonal replacement therapy puts a risk factor, and the genetic factors and what genes are responsible. Please remember these two genes. If there is any mutation in these genes, then there is a chance a person might have ovarian cancer. So BRCA1 gene and BRCA2 gene. So in the exam, what happens? These are very simple questions. Maybe they ask you and mention about how much risk is associated with BRCA1 mutation. Then the answer is, if a person have BRCA1 gene, then the chances of developing ovarian cancer are 40% and 15% with BRCA2. So remember, 40% with BRCA1 and 15% with BRCA2. So for now, we have done 2 SPS. Now let's have a look at protective factors. Multiparity, yes, if a female undergoes, if she goes through the pregnancy again and again, that means she's getting the gaps, like 9 months gap from the ovulation. So that's a protective factor. Oral contraceptives, why? Because oral contraceptives may lead to an ovulation. No egg, no epithelial damage, no risk for having ovarian cancer. Tubal ligation, hysterectomy, bilateral oophorectomy, no ovaries, no cancer. Lactation, because we have some of my students, maybe they remember the physiology of lactation, lactogenesis. We have discussed in detail how lactation inhibits and leads, or you can say leads to anovulation or anovulatory cycles, you can say. So it protects it protects a female for having the risk of ovarian cancer. And some of the protective factors are retinoids, vitamin D, or some NSAIDs, which we use for preventing of ovarian cancer. So now let's have a look the major histopathological categories of ovarian cancer. First, just have a look on the ovary. What are the components of an ovary? If you see on the outside, this is epithelium. So there are major three categories of ovarian cancer. One category which comes from this epithelial damage, and we termed them as surface epithelial tumors, or the simple epithelial tumors of the ovary. That's simple. Then we have another important category, and many questions come from this category, which is germ cell tumor. So what is germ cell? Please please tell me what are germ cells? I hope by this time everyone have done embryology. So okay, that's good. Follicles. And what else? What else we got from the germ cells? Oogonia follicles are the same thing. What else are in the germ cells? The answer is very simple. Germ cells have all the germ layers: ectoderm, mesoderm, endoderm. That's very simple. Germ cells have all the germ layers. So yes, and the oocyte is also the correct answer. Yes, ectoderm, endoderm, mesoderm, everything. Then we have the sex cord stromal tumors, which mainly arise from the stroma of the ovary. And the stroma is the supportive structure of the ovary. Okay, now let's have a look. What are the different categories of epithelial cancers? We have major types: serous epithelial tumors, mucinous epithelial tumors, endometrioid, which is endometrioma. I am sure you have read this topic about endometrioma, which is associated with endometriosis. So it is a chocolate cyst. Then clear cell carcinoma, transitional cell carcinoma, and some of the tumors are undifferentiated. So mainly remember serous, mucinous, endometrioid, clear cell, transitional cell. The second category we have are the germ cells tumor, and the main examples are dysgerminoma. So here is what you are talking about, oocyte and oogonia. So the dysgerminomas are classical tumors which arises from the oocyte or oogonia. So dysgerminoma are basically the tumor of the oogonia. The second type we have endodermal sinus tumor, which is also known as yolk sac tumor. So what is yolk sac tumor? It is a tumor which develops from the tissue, which later on form the yolk sac. So basically, it's a tumor of yolk sac tissue. And again, in the germ cells, the germ cell have all the layers: ectoderm, mesoderm, endoderm. And we know yolk sac, where it comes from. Then we have teratoma. Teratoma involves all the germ layers. So when we look at that teratoma, we will found all the structures, all the derivatives of each germ layer. They could be derivatives of ectoderm, mesoderm, and endoderm. So it have a mixed picture. And there are several types of teratoma. Maybe you may find a patient who have teratoma of ectoderm, and the structures inside the teratoma are mostly the derivatives of ectoderm. And similarly, there may be a combination like ectoderm plus mesoderm, or it may be very severe that it leads to the teratoma of all the germs layer. And next we have choriocarcinoma. Choriocarcinoma develops from that particular tissue of the germ cell, which leads to the formation of syncytial trophoblast. Then gonadoblastoma and mixed germ cell tumors. The third classification, we have sex cord or stromal tumors, in which we have granulosa cell tumor, which are estrogen secreting tumors. Then we have Sertoli leading cell tumor. These are easy to remember. Okay, so the neoplasia of the ovary may metastasize towards breast, colon, stomach, endometrium, or lymphoma. And when we look at the pathogenesis, the ovarian carcinogenesis can be divided into two broad phases. One is the malignant transformation, in which what happens, initially a benign growth develops due to rapidly multiplying cells. And then it invades the basement membrane of the tissue and leads to the malignant formation. And the second phase is peritoneal dissemination. And someone was talking about this, that ovarian cancer is associated with the peritoneum. Yes, because it spreads through the peritoneum. It has translomic route of spread. So that's the second phase of ovarian cancer. Am I clear so far? If you want me to repeat anything, this is just an overview. In the coming slides, we will discuss each and every classification and important and high yield points. So don't worry, we will recap that again. Okay, good. Now let's break down epithelial ovarian cancers. If you find in the exam any SBA and they ask you common type, then go and jump and click on the epithelial ovarian cancers. And there's another subclassification of this recall. If they particularly ask you which one is the most common epithelial cancer among rest of the options, then go with the serous epithelial carcinoma. Because I'm repeating this again, overall, the epithelial ovarian cancers are the most common type. And among the epithelial cancers, the serous carcinoma is the most common type. It accounts for the 68% of the epithelial ovarian cancer. Okay, there are some suspicious histological features of the ovarian cancer. If you take a tissue and make a slide and observe that tissue, and if you find irregular cell surface, irregular cystic regions, and necrosis or hemorrhage, that means that there are high chances of that tumor, that tissue is malignant, and that's a red flag. So these are some red flags of ovarian tissue. Okay, in the exam, sometimes they expect from you to that you know the histological features of important ovarian cancers. So here are the two keywords. If you found in the STEM that in the histological findings, histopathological findings, if you find a serous tumor, pneumoma bodies in the question, then go and look for the serous tumors. And if you find the keyword mucin vacuole, then go and click on mucinous tumors. And again, this is a normal ovary. This is the normal structure: epithelium, theca cell, granulosa cell, stromal cell, and the germ cells. Okay, let's discuss some biostats. There is a 5-year survival of the ovarian cancer is 43%, and lifetime risk is 1 in 70. Germ cell, for now we have discussed that the epithelial cells are the most common. The second one are the germ cell tumors, and the sex cord or the stromal tumors are rare. So this is the order of the prevalence of the ovarian cancers. So again, I have highlighted the high yield points. Now let's start the germ cell tumors. Teratomas. So what happens? Another important difference: the epithelial cancers are mostly common in old-aged women. Maybe you can say around the age of 65 to 70. Whereas the germ cell tumors are mostly common in the young population. Okay, so now let's discuss the teratomas, because there is a SP of teratoma which is frequently asked in the exam. So make sure you know. So there are some categories. It could be mature cystic teratoma or it could be immature. So mature cystic teratoma is the most common type and it derived from all the germ layers. And it may contain, because since it contains all the germ layers, there is a chance it have hair, teeth, fat, skin, muscle, cartilage, bone, endocrine tissue. So it really looks horrible. I have shared this diagram. If you notice here, there is an eyeball, there is a bone, there are hairs, cartilage, muscle, tissue, everything. Some of the tumors are struma ovri tumor, which are only made up of thyroid tissue. And if a person has struma, okay, in the exam, if you find a clinical scenario in which a patient have hyperthyroid features, but her thyroid gland is normal and she has some cyst, she may have some positive findings on the ultrasound, then there's a chance they are giving you the clue to go and choose a struma ovri tumor, because that's a particular tumor which develop from the thyroid tissue and act like that and leads the patient to have that hyperthyroid features, clinical symptoms, and ultimately they have hyperthyroidism. Yes, I think someone's mic is open. Let me check. Okay. So remember, there are many SPs from this table, this slide. You may ask about teratoma, and if they are expecting you to diagnose a teratoma, they will give you some ultrasound findings that maybe there are multiple echogenicity on the ultrasound. That means there are different kind of structures are there in the cyst or in the mass, you can say. So then the answer would be cystic or simply the teratoma. And if they give you the hints or the key findings of hyperthyroid features, along with the positive ultrasound findings, that means you need to go for the struma ovri tumor, which is again the germ cell tumor. The next type, we have the yolk sac tumor, which is also known as endodermal sinus tumor. It develops from the germ layer, which forms the yolk sac, and it is most commonly in the children. What is the key feature? On histopathological findings, they may be scalar dual bodies. And another positive finding is that the alpha fetoprotein would be raised in case of yolk sac tumor. So am I clear so far? Okay, sure, I can repeat. So we were discussing some SPAs, and please make sure you are clear about the differences and you are clear about which type belongs to which layer, because there are many SPAs. I think all of these types have SPAs. They are asked in the exams. We have clinical scenario of teratomas. We have clinical scenario of yolk sac tumor. We have clinical scenario of struma ovri tumor. We have questions on choriocarcinoma, and we have questions of dysgerminoma. So there are 5 questions which are covering from this topic, or from this slide, you can say. And for now, I think we have covered 7 to 8 SPAs till now. So now you can imagine how much important this topic is for the exam. So I'm repeating this again. Teratomas, if you find the keyword multiple echogenicity on the ultrasound, that means multiple echogenicity means there are different type of structures in the cyst or in the mass. There could be hair, teeth, fat, skin, or muscle, or endocrine tissue maybe. So in that case, you need to diagnose or you need to click on teratoma. If in the clinical scenario, they have given you the clinical features of hyperthyroidism, along with the positive findings on the pelvic ultrasound, then go and choose a struma ovri tumor, because that's the only tumor which is related with hyperthyroidism. Am I clear now? Yes, it's a type of teratoma, or in a broader picture, it's a type of germ cell tumor. Okay, next we have yolk sac tumor. As its name indicates, it's a germ cell tumor which particularly arises or develops in the tissue which gives rise to the yolk sac, or the germ layer which forms a yolk sac. It is mostly common in the children. There are two important key points you need to remember. If the examiner wants you to pick yolk sac tumor, he will give you the one or both of these positive findings. The one is the raised alpha-fetoprotein level, and number two, the scalar dual bodies on the histopathological examination. So remember these 2 points. Or they maybe give you the clinical scenario and they give you the diagnosis that this patient have yolk sac tumor. So what are the findings on the histopathological slide? So then in that case, you need to go and pick the scalar dual bodies. Am I clear? Okay, the next we have choriocarcinoma. It develops from the germ tissue, which give rise to the syncytial trophoblast cells. And the classic finding is the beta HCG levels would increase in case of choriocarcinoma. So if you find again a clinical scenario and beta HCG is raised, then go and click on choriocarcinoma. The fourth type we have dysgerminoma. It develops from the oocyte or oogonia, and under microscope they have central nuclei which are clear surrounded by cytoplasm, and they are LDH secreting tumors. So the key word which is associated with dysgerminoma is LDH. So what I'm trying to say, if you find a clinical scenario and on lab findings the LDH level is raised, then what tumor you are going to choose? Choriocarcinoma, dysgerminoma, yolk sac tumor, or teratoma? Please tell me your answer. If you have a clinical scenario and on the lab findings you find that LDH is raised, so which tumor it is associated? Okay, that's perfect. Yes, dysgerminoma is the right answer, and it is honestly it is frequently asked in the exam. So please don't confuse different types of the tumors. Make sure you know the difference, which tumor marker is associated with which type of the tumor. Okay, so the last category we have sex cord tumors or the stromal tumors. Among these, ovarian fibromas are the most common sex cord stromal tumors. They are solid ovarian tumors composed of stromal cells, and they're present in the older women, often with the torsion due to heaviness of the ovary. So these are the fibromas. These are the solid tumors. Okay, in this clinical scenario of ovarian fibroma, you may find a patient who have pleural effusion. That patient may have ascites. So basically, it's a MAKE syndrome, which is a triad of pleural effusion, ascites, and ovarian fibroma. And it is classically associated with ovarian fibromas. This MAKE syndrome is a classical feature of ovarian fibroma. So that's a high yield point from this. Okay, Dr. Bhavna, there are some generic clinical features of all the cancer. And those generic features are weight loss, any lumps or bumps in your body, chronic pain, loss of appetite, on and off fever, recurrent infections. So these are the generic, or the lethargy, body weakness. These are the generic clinical findings, and anyone can have these symptoms. Even if a patient have bladder cancer, testicular cancer, ovarian, cervical cancer, all of them have same features. So that's why it is important for us to thoroughly examine the patient and go and check the tumor markers. Okay. Next, we have granulosa cell tumor. And again, all of these are asked in the previous exams. We have questions from ovarian fibromas as well, granulosa cell tumor. Okay, so what is the question from granulosa cell tumor is that there is a question which they ask about which of the following cancer, ovarian cancer, is having the risk of developing endometrial carcinoma as well. So the answer is granulosa cell. This is the cancer which is associated with endometrial carcinoma. Am I clear? Okay, or if I put this in another words, what is the effect of granulosa cell tumor on the endometrium? Please tell me. My question is, what is the effect of granulosa cell tumor on the endometrium?
Can I ask? Can I answer?
Yeah, sure.
Granulosa cell tumor is characterized by secretion of estrogen. So the effect on the endometrium, it will lead to increase the risk of endometrial hyperplasia, which may later on increase the risk for endometrial carcinoma.
Yes, excellent. That's the perfect answer.
Thank you.
Well done. So it have the granular cells, yes, since they are estrogen secreting tumor, they lead to the proliferation of endometrium, and then this proliferation leads to hyperplasia, and that hyperplasia may lead to endometrial carcinoma. Okay, signs and symptoms. There are some non-specific GI symptoms. They may include nausea, dyspepsia, altered bowel habits, and these are the complaints, these are the symptoms which patient comes to you and tell you that I have these problems. And when you examine the patient and when you particularly do the abdominal examination, you may find the abdominal distension, which may give you an idea that disease is advancing. And on lymph node examination, please remember Sister Mary Joseph nodule. If you found these nodules, which are basically on the umbilicus, that gives you an idea that the tumor has been metastasized towards the umbilicus. So Sister Mary Joseph nodules are specific for the ovarian cancer. Okay, generically, what kind of investigation we do? We start with CA-125 levels. Then we have, again, we need to rule out. We need to do CA-125, we need to do LDH, we need to do HCG, and we need to do alpha-fetoprotein so that we can differentiate that with what kind of ovarian cancer a female have. So this is a summary. If anyone have any question, you may ask me. If you are clear, if you have no question, please do let me know so that I can move on to the next slide. Okay. Okay, if now we have a patient, we do check her tumor markers, but we want to assess her risk of having malignancy in the future, so that we can manage that patient accordingly. So what is the criteria? How we can do that? So thankfully, we have a formula which we called as risk of malignancy index. So what we do usually, if a patient comes to us, we go with the pelvic ultrasound, we go with the CA-125 levels, and meanwhile, we will also assess the menopausal status of the female. And once we have all these three things, then we give them some score and found out the final value. And that value will tell us, give us the idea that how much that person have a risk of having malignancy of ovarian cancer. So let's have a look. And again, there are many questions which come from this slide. You may find directly some SPAs in which they ask you about this formula. Maybe they switch around some information. Maybe they replace this cross sign with the plus sign. Maybe they replace the cross sign with the minus sign, minus or plus sign. So make sure you choose the option which shows that we multiply ultrasound score with menopausal score and multiply that with CA 125 levels. So make sure you go with the right option. So one SPA done. The second type of category of questions we have, they give us some findings of a patient and ask us to calculate RMI. So how would you calculate RMI? Let's have a look on ultrasound features. If in the clinical scenario or in the question you found multilocular cyst, solid areas, ascites, intra-abdominal metastasis, then give the patient 3 score. So in a nutshell, if there is no finding in the ultrasound, give 0 score. If you found one abnormality among these, give 1 score. If you found 2 or more abnormalities, then give 3 scores to the patient. Then look at the age of the patient. If she is postmenopausal, then give her 3 score. If she's premenopausal or a young lady, then give her 1 score. And CA125 levels are usually given in the scenario. Just pick that value, multiply your score, and found out your result, and go and click that option. That's it. So a score more than 200 is suggestive of high risk for ovarian cancer. Some books says it is more than 250. However, just remember the range. It is classically more than 200, or it could be more than 250. In both of the cases, the highest that score is suggestive of high risk for ovarian cancer. It is RMI scoring. And sometimes they ask you question, they may mention about ultrasound score and menopausal score and ask you about the third option, like which another thing we need to calculate RMI. And sometimes they may mention CA125 or ultrasound score and they skip this option. Then in that case, you need to go and choose a menopausal score. Anyways, just remember you have to complete 3 things. You have to multiply 3 factors, which is ultrasound score, menopausal status, and CA125 level. That's it. This is easy. I don't think so anyone found this topic difficult.
May I ask question, Dr. Sombor, please?
Yeah, sure.
Could you return back to the previous slide in the risk malignancy index score?
Yeah.
In ultrasound features, I guess is another one on the ultrasound features. If the lesions is bilateral, is another an option of them. In addition to the multilocular cysts and solid areas and ascites and intra-abdominal mets, bilaterality of the lesions. It cannot sometimes.
Okay. Well, it depends on the presenting findings of the patient. In the clinical scenario, if the patient comes with a unilateral swelling or the mass on the right side of her pelvic region, then definitely there is a 1 cyst.
No, sorry. My question is, if in the question by ultrasound they said there was bilateral in both ovaries. There was 2, for example, 2 multilocular cysts in both ovaries, right and left. Bilaterality, it's considered an item and it's scoring 1.
Yeah, that's score 1. Yeah, that's score 1.
So bilateral, if the lesions is bilateral, it's an additional score for ultrasound. That's my question. Is it right or not? I'm not right?
Okay, so let me repeat your question. You were trying to ask me, since I have mentioned about one feature, if that feature is present bilaterally, so what scores I'm supposed to give that feature?
Yes, exactly. Okay. That's my question.
So in case in the ultrasound finding, you find the multiocular cyst bilaterally, give 1 score. If you find just solid areas on the both side of the ovaries, give 1 score. That's the one feature. If you find multiocular cyst or solid areas in both the ovaries, then you can go with the 3 score.
Okay, thank you.
Welcome.
It's
However,
clear.
bilateral ovarian cancer is rare. Mostly well, that's there are many patients who have bilateral cancer, but mostly the unilateral ovarian cancer is more prevalent.
Yeah, yeah,
So
yeah.
hopefully you, because the MRCG1 exam is very basic exam, and they don't expect from you to have some advanced and master knowledge and master management for everything. So hopefully you will find a question in which they ask about unilateral features.
Okay, inshallah. Thank you.
Sure. Welcome. Okay, so next is staging, and the good news here is that there are no questions from the ovarian cancer staging in the recalls, because mostly as far as the RCG is concerned, their most favorite topic for the staging are the cervical cancer, endometrial cancer, and the vulval cancer. Because in ovarian cancer, they have many favorite topics already. Like they have many questions. Even if I go back from the risk factors, they have 4 SPs from this slide. Then from the types, and from the epithelial ovarian cancer, they have many questions. And again, from the germ cell tumors, they have many SPs. Again, from both of these tumors, from the fibromas and the granular cell tumors, there are many SPs. Then they have questions from these investigations. They have questions from Sister Mary Joseph nodule. They have many questions from the risk of malignancy index. So there is no point they will ask questions from the staging. However, I'm not encouraging you to skip this topic because RCG is unpredictable, but just have an overview. This is easy. This staging is easy. So let's have a look. Okay, Dr. Larib, your question is bilateral in its SERV score 1. So if bilateral lesion plus unilocal. Okay, now in your question, there is an answer. If there is a bilateral lesion plus unilocular cyst, that means there are 2 features there. One is the lesion, then other is the unilocular cyst. Either it is present on one side, but now you have 2 pathologies. And when you have 2 features, 2 or more, then score 3. Okay, now let's begin with the staging. So what I mostly advise my students, I shared a tip with them that whenever you are studying staging, first of all, remember the summary of each stage. In FIGO staging system, we usually have stage 1, 2, 3, and 4. So what is the summary of ovarian cancer? Summary means you know in each stage what is the involvement of the cancer. So in stage 1, it is limited to the ovaries. In the stage 2, it is limited to the pelvis. Now imagine in your mind how we are going from the different organs of the body and how the ovarian cancer is involving different parts of the body. So since it's the ovarian cancer, so it begins from the ovaries. So stage 1 is limited to the ovaries. And since it is limited to the ovaries, it is less malignant. There are good prognosis at this stage. Then the second stage is limited to the pelvis. Third stage is limited to the abdomen. And in the fourth stage, distant metastasis, which is outside the abdominal cavity. So if you remember the summary of each stage, it is very easy for you to understand the sub-staging of each stage. So now let's have a look. Please revise with me. Stage 1, limited to the ovaries. So what substages we have? 1A and 1B. In 1A, one ovary is involved. In 1B, both ovaries are involved. Okay, we have 1C as well. In 1C, there is a ruptured capsule, surface tumor, or a positive peritoneal washing or ascites. So now, please note this point. Even in the stage 1, there may be peritoneal washing or ascites. So don't consider or don't label a patient with the stage 4 if you found that the patient have ascites, because now you are imagining that there may be metastasis going on. No, again, even in the stage 1, there could be ascites, there could be positive peritoneal washings. Okay, so the second stage is limited to the pelvis. We have again A, B, and C substaging. And when we look at the A, it involves uterus and the fallopian tubes. In the 2B, other pelvic features are also involved. In 2C, these above features plus ascites or peritoneal washing. This is common with every C substage, peritoneal washing or ascites. Then stage 3, it is limited to the abdomen. There could be in 3A, B, and C, again, 3 substages. In A, microscopic metastasis. In B, macroscopic metastasis. And in 3, more than 2 centimeter plus regional lymph node involvement. So if someone asks you, if someone gives you the staging and they have mentioned that there's regional lymph node involvement, so what stage it could be? Please tell me in the chat box. If you find that keyword regional lymph nodes involvement, so what is the stage of that ovarian cancer? Okay, so what I'm trying to put in your heads is that if you find again ascites or peritoneal washing, don't assume that this is stage 3 or 4, because that's common throughout the ovarian cancer. And the regional lymph node involvement is particularly is the classic finding of stage 3C of the ovarian cancer. And what happens in stage 4? There is distant metastasis outside the abdominal cavity. It could be metastasized towards the breast, lung, or anywhere. And with this, you can see 5-year survival rate of each stage. If a patient is diagnosed at this level, stage 1, which is limited to the ovaries, there are 75 to 90% chances of their survival in the 5 years. And now you can see with the advancing staging, the prognosis is decreasing. In stage 2, it is 60%, 45 to 60. In stage 3, it is 30 to 40%. And in 4th stage, there are less than 20% chances of the patient survival. Am I clear? Okay, now let's revise the staging again. Stage 1, limited to the ovaries. Stage 2, limited to the pelvis. Stage 3, cancer has spread beyond the pelvis, and it may involve the abdomen, plus the classic finding is lymph node involvement. And in stage 4, there is distant metastasis. Okay, so here is a quick reminder. Our Power Hour course booking is open until May 15th. So by that means, after 15th of May, we are not taking any other student. So the time window is very short now. So don't miss out on this opportunity, because your time, career, and your money are valuable. And I understand how expensive this exam is. So don't put your money on risk, and well prepared for the exam. Let me give you a brief of our Power Hour course. We have structured schedule guided by RCG examiner. We have interactive live sessions, which are subject-wise. There are recordings of all sessions are available. There is daily 2-hour recall practice with mentors, particularly on the Telegram group. We have subject-wise recalls and year-wise recalls. And the good thing about this schedule is that you may have this opportunity to discuss all these SPAs on the Telegram group with us, or any of us, our mentors. So we have updated question pool of all the subjects up to 2024. And here's another attractive thing about this course is that at the end of every session, we have mock exam. And once we are done with each subject, each module, we have exam rehearsal mock, and we have exam rehearsal month as well. And before the exam, you may have 3 big mocks as well. So how do you think about all of these things? And honestly, if you follow this pattern, there are many chances you will revise all the SPAs and the recalls at least 3 to 4 times before the exam. And I have mentioned that already so many times that revision is the key to pass this exam. If you have a good grip on those recalls and you have crystal clear understanding, then nothing can stop to pass this exam. Okay, so now I have a quiz for you. So my question is, you are assessing a patient with an ovarian mass and are using the risk of malignancy index 1 score. Which of the following is used to calculate the RMI? Okay, I think we have the maximum answers. Okay, B is the right answer, CA 125. That means everyone is listening to me. Everyone's answer is correct. Well done. Okay, my next question is, a 35-year-old woman attends clinic following laparotomy and unilateral oophorectomy. The histology shows smoma bodies. What type of tumor would this be consistent with? Okay, your time's up. A is the right answer because smoma bodies are classical histopathological finding of serous carcinoma. Please tell me, serous carcinoma is which type of ovarian cancer? Is it germ cell tumor? Is it stromal cell tumor? Is it epithelial tumor? Okay, that's wonderful. So let me give you a count how much SPs we have done so far. Let me calculate them so that you would be satisfied. And I want to put your mind on ease. I know this time is very crucial and everyone is under stress because all of you have put a lot of money on this exam and I don't want to risk any of your money. So we have done 1, 2, or 3 from this slide, 3, 4. Okay, this is the summary. Almost 3 questions from this slide, 3 or 4 questions because they ask about general epithelial cancer percentage and the serous percentage. Okay, so 3, 6, 7, 8, 9, 10, and many, many, many SPs from this. You may count 8. So 6, 8. Please someone add this for me. I'm very poor in mathematics. So 2 or 3 SPs from this slide. It counts, I think it's around 17 or 18 till now. 18, 19, or 20. They will ask you together about all of these tumor markers. There is an SPA in which they ask about all the tumor markers. That if a younger, there is a scenario in the recalls, that a younger presented to the clinic and she have her ultrasound with her, and on ultrasound she have some mass. So now what lab you are going to order, which tumor markers you are going to offer her. So the answer is all of them: CA125, LDH, HCG, alpha fetoprotein, because you're unsure about which type of cancer she have, which type of tumor she have, and what type of that tissue mass is all about. So in that case, you need to rule out every tumor, every type of tumor. So you will go with the CA1 to all of these tumor markers. So 3 SPs from this slide, and we have covered RMI. There are 2 to 3 types of SPs from this slide. So there are more than 20 SPAs we have covered so far from the ovarian cancer. So now you understand how high yield this topic is and why we met Instutors, we arranged this webinar for you. Okay, if anyone have any question from this topic, please you can ask me. Welcome, Dr. Larib and Dr. Melna. You should be thankful to Med Institutors because they provide us this platform. Even they provide me this platform that I'm teaching you, everyone. So say thank you to Med Institutors, not to me. Okay, one more time, I want to give you the reminder that our Power Hour course, we are not taking any more students after 15th of May. So the booking window is open till 15th of May. If you want to take this opportunity, so this is the right time. Okay, so the association of BRCA1 and 2, BRCA1 is 40% and BRCA2 is 15%. This is very, very oftenly asked in the exam. Okay, Dr. Iram, I have a question for you. Which is the most common risk factor for having ovarian cancer? Your options are gene mutation, smoking, family history, oral contraceptives. Which one is the strongest risk factor for a woman to have ovarian cancer? Dr. Bhavna, please replace that genetic word. Family history is the most common cause. Dr. Iram, Dr. Sophia, your answers are right. Okay, someone has requested to arrange a session on research tools. Okay, we can discuss this idea. I can discuss this idea with my team, and we will let you know once we are sure about that. Okay, I have another question. Which of the following ovarian cancer is associated with hyperthyroidism? Your options are theca cell tumor, Sertoli cell tumor, dysgerminoma, stroma ovari tumor.
Excuse me, could you just repeat the question again?
Okay, my question is, which of the following ovarian tumor is associated with hyperthyroidism? And your options are theca cell tumor, Sertoli cell tumor, dysgerminoma, or stroma ovari tumor. Okay, yes, that's wonderful. Perfect. Okay, I have another SPA. Which of the following tumor is associated with increased LDH level? Your options are serous cell tumor, serous cyst adenoma, dysgerminoma, or germ cell tumor? Okay, I have a, yes, that's perfect, dysgerminoma. I have another question. We have a patient in our OPD, and she have her ultrasound findings with her. On ultrasound findings, she have a mass. So we did a procedure. We took her biopsy and sent to the histopathological lab. And once we have those findings, we found that they are scalar dual bodies. So which of the following tumors are consistent with these findings? Your option A is endometrial sinus tumor, option B, endometrioma, option C, clear cell carcinoma, option D, mucin tumors. Okay, perfect. Why I'm asking this question, because I want to make sure because you have spent your 1 hour with me, and I don't want you to waste your time. And I want to make sure if you spend your 1 hour, then you are taking something with you. Okay, last question. Okay, let me think which one we are left with. Okay, so which of the following tumor is associated with endometrial carcinoma? Thank you, Dr. Iram. Which of the following tumor is associated with endometrial carcinoma? Okay, that's wonderful. I even didn't give you any options, and you all know the right type. Okay, that's wonderful. Granulosa cell tumors. So now today you are done with more than 20 SPs from pathology. And I'm sure at least 2 questions will come from this topic in the exam. Okay, there are some pet topics in which there are 100% chances that questions will come from in the exam. And some of them are the 2x2 table from the biostats. And there's another topic in embryology that pharyngeal apparatus. So these are some of the topics in which definitely 100% you will have some questions. So make sure you have a good grip on those. Welcome, Dr. Saiba. Again, thanks to Instutors, because they provide us this platform that we are learning from each other. And many times, honestly, I learned from you. Which 2 topics? Actually, there are many important topics, but for now, as far as I remember, this ovarian cancer, yes. Then 2x2 table from biostats. And I'm 100% sure you will get 2 or more than 2 questions from 2x2 table. So if you've done 2x2 table by heart, then definitely you will cover some of the biostats SPAs in the exam. Then we have 100% probability topic, pharyngeal apparatus from embryology. Yes, definitely. Thanks for reminding this, because for now I'm too much saturated with pathology. Yes, definitely. Alkalosis and acidosis, 100% chances. And there are many other topics like that. Okay, if anyone have no question, we can close our meeting. Thank you, Dr. AM. That really, really, really means a lot. And there is something bad associated with me. What happens, I have been teaching for many, many years, and I have been teaching since my student life. And what usually happened with me, I teach my friends, I teach many of the people, I teach many Lab 2 candidates, and every time they pass the exam and I failed that exam. It happens with me so many times. So I think whoever learned from me, they passed the exam. But for now, I'm on the safe place because I am done with this exam. So I'm risk free. And unfortunately, this is another bad thing. My friends, my colleagues, or my students, they never came back to me and asked me, did you pass the exam? Because somehow they assume that I already passed the exam. And deep down, I knew that I failed that exam. So no sympathies for me. Maybe I won the life. Dr. M, that really, really means a lot to me. But for now, make sure you pass the exam in one go, because you have really put a lot of money and you are sacrificing your personal life. You are studying hard for this exam. You are managing your study time along with your clinical practice. So please make sure you take maximum, utilize this time, utilize every opportunity that comes your way. Dr. Iram, you may move to Lahore. Yes, definitely. Okay, any other questions? Okay, Dr. Iram, if destiny has chosen us to meet one day, then definitely we will meet. Inshallah. Binhal, are you there? Okay, so I think we are done with the questions. Goodbye, everyone. See you tomorrow in the free WhatsApp group.